right after my procedure, when I had my first food, the moment it went inside down like this, I had tears in my eyes. I'm like, wow, is it this easy eating food?
We have effective symptomatic treatment. What we don't have is disease modifying treatment. Achalasia is considered one of the poster childs for a neuro-GI or neurogastroenterological disorder because the hallmark of this condition is a loss of the nerve cells around the lower esophageal sphincter. The lower esophageal sphincter is this ring of muscle at the junction of the esophagus and the stomach. It acts like a valve, so it opens up when you swallow, but when you're done, it closes to prevent the acid or food from coming back. And that opening and closing, that relaxation and contraction is under the control of nerves. And when the nerves are missing, then those functions are lost. So in achalasia, those nerves that cause relaxation of the sphincter, causing it to open up, are lost. On top of that, with time, a lot of patients with achalasia lose their ability to push food down through contraction, what we call peristalsis, which are an orderly sequence of contractions going from the top to the bottom, squeezing the food, pushing it down. Those contractions are lost as well. So you have kind of a double whammy. You don't have a good, strong pump, but then at the end, the pipe, there's a valve that remains shut. Now, most of us can learn to swallow without peristalsis because gravity, if you stand up, gravity can push things down. It's not ideal, but that by itself doesn't cause the problem. It's that closure of the sphincter that is the most important thing in the symptoms of achalasia, which is why until now all therapies really have been directed at opening up that sphincter, causing it to relax.
We have the problem of this achalasia diagnosed, which is non-relaxation of the valve between food pipe and stomach. What can we do as a doctor? So as a doctor, we can reduce the pressure at LES so that the food falls from food pipe into the stomach easily without getting obstructed. But all the treatments which we do are palliative in nature because we are just disrupting the lower esophageal valve. So this valve can be disrupted by chemical methods or by mechanical methods. Chemical methods like medicines or Botox toxin, where we can transiently, maybe if we inject Botox, which paralyze this valve. If we inject there, this valve kept open for a long time and the swallowing problem goes away. But that Botox has got certain limitation because it will last for 6 months to 1 year. Similarly, the medications, every time patient swallow has to take one medicine like calcium channel blockers. Again, there is a drawback that it has to be taken every day, every meal, which is not practical. The second thing as a doctor, what we can do is to do dilatation. We can inflate a balloon forcibly, but this is very uncontrolled. or it may cause serious problem like perforation. So that's how the balloon is not a preferred option.
The most common and the most effective therapies for achalasia are this, what we call a myotomy, which is cutting off the sphincter muscle.
So he patiently sat and explained me the different stages of the insomnitis. If in case I would undergo take the palliative procedure, now it goes into the kind of exercise esophagus, which becomes more non-treatable kind of a thing. So when we start with the explore the options, he did talk about something called myotomy. The process of myotomy, like I can remember this, that he kind of told there we have multiple incisions outside.
So basically it means small 4 holes, they are called as buttonholes, which are about 5 mm in size. And in usually 4 such holes, you can get a small endoscopic or a laparoscopic camera with the instruments that we operate. And one energy source may be required. So with those 4 holes, basically at the lower end of the urbi, you just split the muscles. It's a controlled sprickage. You just have to take care if there is some small ooze that needs to be taken care. And otherwise, it is just the splitting of the muscles. So in the advanced disease where the shape of the food pipe is changed and there are many curvatures, Ehlers myotomy may be a better option because you can do the myotomy in a better form, and because you are doing bigger myotomies or longer myotomies, the anti-reflex procedures needs to be added more in these patients.
So the surgery can be done by laparoscopic method, coming from skin to inside, reaching to that LES, the valve, and cutting that valve and suturing outside. That's all. While in endoscopy, we can achieve the same result of cutting the muscle which is not relaxing, that is valve, that is LES, by endoscopic method, and this procedure is known as POEM, per oral endoscopic myotomy.
AG, we were one of the first, not only in India but in the world, to start doing POEMs. POEM procedure itself was innovated by Professor Harrow Inouye, who is a close friend of mine. 28 he first did the procedure, then 2010 he published this, and then he came to AIG in 2012, so where we did a lot of teaching and so on, and then established the procedure. 2013 we did the first live demonstration to show to the rest of the doctors, not only in India but over the world, that this procedure is possible.
It's such a non-invasive, non-blood loss, non-painless. It's like a smooth procedure that one can undergo without any fear of anything, with the best results that I can anticipate out of it.
POEM is not one. POEM can be done in many different ways. So we did randomized control trials to see whether short POEM is enough, long POEM. Earlier we used to do 13 centimeter incision, but now we cut it down to 4 or 5 centimeters, and exactly we have mapped out which part of the muscle has to be cut to be more effective, very short. Also we have done studies to show how to avoid reflux, because many of these patients can develop reflux esophagitis. This is one of the commonest problem with POEM. So we have shown how to avoid this reflux by adapting or changing the procedure a little.
So we keep them under close observation for 3 to 4 hours, and once the recovery happens, they are shifted to the ward and they are kept nil by mouth for 24 hours. And once 24 hours are passed, we ask them to take liquid, and once they are tolerating clear liquids, we ask them to take soft diet in front of us. In next 48 hours they are ready to go home.
So I remember the procedure, and then the moment everyone woke me up on the bed there, my first question to the doctor was like, "Can I eat now?" I being got all the doctors there, everyone standing there and laughing out loud the moment my question was from 5 years I've not been eating anything. I've been starving there from the day I got admitted to the hospital. For the first solid moment when I had that food, I could feel that the food just easily went inside without any effort. I never ever knew that I can eat food like that.
Ask the patient is to again come back to us in next 3 months time for evaluation. So we monitor these 4 symptoms: the degree of swallowing problem, the degree of food coming out as a regurgitation, the weight gain, and the chest pain. And once we are happy that okay, these patients have got good symptomatic improvement, we do one more objective assessment of the patient at 3 months to see that not only the symptoms have relieved, but also the test which are we going to do, like barium swallow, is not showing any further stoppage of that medicine. The X-ray is clear, and also the pressures in high resolution manometry is also okay. That means the pressure at LES is now under the accepted limits. Then we say that patient has good symptomatic relief, good objective evidence of relief. These patients do well for long.
So when you do the myotomy, when you cut the muscle, you'll certainly cause the food to drop down much more easily into the stomach. But now there's nothing to prevent contents of the stomach from coming back up. So these patients are at risk for reflux disease, and that's why often they have to be tested and put on acid suppressive medications. Because what you don't want is acid coming back into the esophagus in somebody who has achalasia, because they have no effective mechanism to clear that acid, and acid will linger for a longer time and can cause inflammation. And over time, sometimes what we call strictures, which is scar tissue, and that causes a permanent deformation of the esophagus.
We keep a very close watch on reflux. We give 3 months completely proton pump inhibitor, and then come back to as and when required proton pump inhibitor. But if patient is requiring proton pump inhibitors or medicine to suppress their acid, we do a pH metry, 24 hours to 48 hours pH metry, to know whether this heartburn is because of acid reflux or something else. We can quickly pick up and tell the patient about the lifestyle modifications or do additional procedure.
अंदर से थोड़ा सा मनाल है कि ठीक हो जाए, अब दोबारा ना कराना पड़े। 25 साल कट जाए, 25 साल कट गए, 25 साल और कट जाए, लाइफ हो जाए, उसके बाद अपन के ऊपर है, अपन उसको जितना अच्छे से कर सकें। नहीं करेंगे तो फिर प्रॉब्लम आएगी।
But we have effective symptomatic treatment. What we don't have is disease-modifying treatment. And disease-modifying treatment is going to the root cause.